Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What are the surgical approaches to colon cancer, diverticulitis, and hemorrhoids? Find out more right now. My guests this evening are Dr. Bradley Bennett and Dr. Vivek Patil, noted colorectal surgeons practicing right here in Montgomery County. Dr. Bennett, Dr. Patil, welcome to Housecall.
Thank you.
So we'll start off with you, Brad. Tell me more about your professional background.
Well, I'm a colon rectal surgeon that's been practicing in Montgomery County now since 1983. I was trained locally at both George Washington University for my general surgery training and at Suburban Hospital where they had a colon rectal training program.
Very good. And Vivek, where do you practice? And tell us about your background.
So I'm also a colorectal surgeon like Dr. Bennett here, and I'm actually a Maryland native. I was trained early medical school and training in DC at Georgetown University.
Nice.
Then I went up to New York for my residency and came back down to MedStar for my colon rectal fellowship. I've been in practice mainly in the Bethesda, Rockville area for about almost 15 years now.
Very nice. So we're going to start off with you, Brad, and let's discuss this very important topic, colon cancer.
Mm-hmm.
First of all, how common is colon cancer nationally and within our community?
Well, nationally, it has an incidence of about 1 in 25 people. It actually is higher than most people think. It's interesting in that it's the age group that people get it is actually changing. We're seeing it a significant increase in young people with this problem over the last 5 to 10 years.
And why do you think younger people are developing colon polyps and by extension colon cancer?
Well, we really don't know. The significant part of this problem is genetic, but still they keep looking at that and only are finding a 5% to 10% instances that they have genes that they can trace. So the actual reason why it's becoming a more common problem in 30 and 40-year-olds is not clear as of now.
Vivek, are you seeing the same phenomenon?
I am seeing that in my practice. Unfortunately, people in their 40s and 50s are presenting very commonly, and even up to 30s, and unfortunately I saw someone in their 20s as well.
Yeah. Certainly I, as a gastroenterologist, is seeing the same phenomenon. And as you know, the societies have traditionally recommended first screening colonoscopy at age 50, in African Americans beginning at age 45 because of a higher genetic risk. But now there's talk about slotting that age criteria earlier, maybe 5 years for everyone. So if somebody has rectal bleeding, should they assume that it's hemorrhoids?
Well, we used to put a rather significant age criteria on this. I think under 40 years old, we would check the rectum in the office, which we can do sort of quickly. And if we saw bleeding hemorrhoids, that we would immediately go to treating the hemorrhoids. I think now we're becoming much more careful about that. I think that we're doing colonoscopies as part of the evaluation for the bleeding on much younger patients now. Yeah. We don't know how young to stop. Certainly in 20-year-olds, I think that we are still doing that kind of treatment plan. But once they're in their 30s and certainly in their 40 and they hit 40 now, I think everybody's getting colonoscoped.
Sure. What's the youngest you've seen for colon cancer?
26.
Yeah, I diagnosed one a few months ago at 32. Mm-hmm. So it's a real and frightening phenomenon. Yeah. So if somebody is diagnosed with colon cancer, what are their surgical treatment options?
I still think that you have to understand that for most of the people that we're treating, that surgery is certainly part of that treatment and the primary cure. It has changed over the years in that as part of the patient's evaluation for their colon cancer, they get X-ray examinations to look for any signs of spread of their cancers. And now some of the patients who have spread are treated with medically first and may not come back to surgery until far down in the treatment of their disease. So now it's much different. We operate on everyone that had cancer early on in their treatment, and now that's changed.
Why is that? What is the advantage of doing the medical approach first?
Well, the problem always was that surgery most of the time comes out without complications and patients recover quickly, but it's still a risky procedure, and any complications that would happen in the postoperative period, it could even be a minor infection, would delay the start of their chemotherapy significantly. And I think they realize that, and now they feel it's best a patient with spread to treat them globally from top to bottom prior to surgical intervention. So we don't want to delay their treatment of their distant metastatic disease if we can.
There are viewers that are worried that if they go on and get a screening colonoscopy and a colonoscopy finds a cancer, that means an automatic colostomy bag. What would you say to those viewers?
I would say earlier last century, that used to be a very common treatment. Nowadays, we take great pains to spare the sphincter muscle and allow for the unlikelihood of a permanent colostomy. Now, there are times when one would need a temporary colostomy. There are very certain indications for that. However, most of the time and most patients you treat surgically will not need a permanent colostomy. Certainly with colon cancer, that's a very small possibility. With rectal cancer, it's slightly higher, but still, I would say overall fairly low.
Now, if somebody needs a surgery, is it always an open procedure, or are there other surgical options to approach it?
Sure. Nowadays, we tend to do less and less open surgery with the advent of specific minimally invasive tools that have been developed over the last few decades. I would say in the 90s is when laparoscopy started to take off and began to be adopted for colon resection. At the turn of this century, it's been more turning towards robotics. So both of these are a tool, or I should say both of these are tools in that the surgery itself, the essence of the surgery remains the same, which is to remove that section of the diseased intestinal tract. How we do it now, though, is minimally invasively, and that is much more common than open surgery.
Once it's completed, do many patients still get postoperative chemo or radiation?
Those that need it certainly do. It depends on the final diagnostic pathology for it.
In other words, whether it's confined or
correct.
spread.
So if it happens to be contained solely within the colon, oftentimes, especially if it's not a very aggressive tumor with aggressive features, then oftentimes people do not need chemotherapy. Once it is outside of the colon, spread into the lymph nodes and certainly into distant parts of the abdomen, chemotherapy is almost always indicated.
Now, Brad, there's a term that is in the surgical literature, enhanced recovery. What exactly is enhanced recovery?
Well, that's a two-part program. With the advent of the minimally invasive or small incision surgery, the recovery of the patients outside of the hospital has been significantly improved. For example, where patients used to be a month before they'd be able to drive a car, now they're driving in 2 weeks. So it's decreased their recovery time, probably about 50% for normal activity. But the other part of it is the in-hospital recovery. And even for our open procedures, patients are placed on enhanced recoveries, which get them out of the hospital much faster. They start walking faster earlier during their stay. They are eating earlier. And all of these things, which we used to think would be dangerous, have now found to actually speed up their recoveries. Along with that, we have trying to get away from the need to use narcotics as the primary pain medication. We found that it's a double-edged sword. It slows people's recovery, and you can use multimodal pain relief during their stay, and they have less pain, less narcotics. They're up and around, they get up and around faster, they leave the hospital faster. So it has what we're doing in the hospital now has changed a lot to get patients out of the hospital quicker and actually with less pain than they used to be.
A nice improvement.
It works.
So, Vivek, do you view treatment of colon cancer as the same as rectal cancer, or do you think they're similar but somewhat different entities?
I would say they are similar along the same spectrum, but the treatment is different, and it has to do a lot, probably primarily with location. So the colon is essentially the large intestine outside of the pelvis, whereas the rectum is within the pelvis. How that changes things is that the rectum remains confined in a small space, and the surrounding lymph nodes thereby remain confined in a small space. So with rectal cancer, the spread to those lymph nodes is something that could cause recurrence in the future at the local level, meaning within the pelvis. With colon cancer, that spread is more of a diagnostic step where it indicates, or prognostic step, I should say, that indicates spread of the colon kind of on a continuum to metastases. So when you remove rectal cancer surgically, you must be sure that you remove all of the lymph nodes instead. It's something called including all the lymph nodes, I should say, and that's something called a total mesorectal excision. Because if you leave any of those lymph nodes behind, it could sprout a new recurrence in that particular area. That doesn't happen with colon cancer. Because of that, what we do often is we treat people before surgery with chemotherapy and radiation. And what that does is it's an attempt to kill those cells before even going after them at surgery, to decrease local recurrence, and it has shown to do that.
And do you find it significantly shrinks the tumor so it's easier to resect?
It can. It depends on the patient, of course, and the tumor type. We don't understand all of the biology yet, but up to 20% of patients actually have a complete response, meaning the tumor completely disappears. And there's been some discussion, certainly in the literature, it's been done very commonly in countries like Brazil, for example, where they actually don't do surgery in those patients, and they watch them, and they happen to have a pretty similar recurrence rate, low recurrence rate in patients as compared to patients who have surgery. So that is still on clinical trial here in the United States, but that may be something that we look at more directly as time goes on in the future, because of the ability potentially to avoid complicated surgery.
We have 1 minute before we go to break. Dr. Bennett, let's go discuss anal cancer. How is that different from rectal cancer?
It's a hugely expanding problem. It is mostly related to a viral infection. It is a similar viral infection that women have been suffering with cervical cancer for as long as doctors have been taking care of patients.
Human papillomavirus.
Human papillomavirus.
Yeah.
The type 16, 18 traditionally are the ones that cause it. Traditionally, it seems to be it's what's causing an increased problem in the anal area.
Right.
It is a skin cancer, and therefore much different than a rectal cancer. Rectal cancers come from the lining of the intestinal tract, and these human papillomavirus are really a skin cancer. Like we see, like they saw in the cervix, and actually you're seeing it in the throat and tonsil area also. And it's not treated with surgery very often, and most of the time it is responds to radiation therapy and chemotherapy. It can, however, be aggressive and spread and cause significant problems if it leaves the area.
All right,
So,
well, thank you for your thoughts on that. We're going to pause briefly for a public service announcement. More with my guest, Dr. Patil and Dr. Bennett, in a moment. We'll be right back.
So there you are, shuffling through a stack of resumes, and you come to mine. This is it, first impression, my way in. But can my resume show you how I truly stand out? Like that I was studying, going to night school while working 2 jobs just to help my parents pay for groceries. Or being the first one to always step up. No, that's something you just can't put on paper. Look beyond the resume and discover new ways to develop great talent that is dedicated, hardworking, and determined like me.
We're back. My guests this evening are Dr. Vivek Patil and Dr. Bradley Bennett, and we are discussing colorectal surgery. So, Dr. Bennett, let's start off with you. Let's discuss diverticulitis. What exactly is that?
Well, for some reason, people get these small outpouchings in the colon, and we're not exactly sure why. We've had lots of ideas through the years that they were related to diet or they run in families, but we really don't know why people get them. Most people live with them throughout their life and never have trouble. I think that they're seen in 25, 35% of the population. But occasionally people have trouble with them with infections from them rupturing and causing troubles. And these troubles can be either a recurring nuisance, a one-time episode where people never, or occasionally the patients will need surgery for it.
And what do you think are some of the reasons that people develop an infection of these diverticuli? Any thoughts about that?
Well, just like Dr. Bennett was saying, we don't have a clear handle on that. We used to, for example, say that because of the theoretical weakening of the colon with infection, after 2 infections you get surgery, because what we're trying to prevent is sudden perforation of the colon, which is of course a very morbid situation for a patient. We found that if we really kind of drill down on people's individual disease process, what we should do now and what we have been doing is really kind of seeing who actually will turn out like that and who won't. So there are plenty of people who have one episode and they take some antibiotics and they do fine and they may not have another one for 10 years. And there are other ones who present on their very first episode with significant diverticulitis with a localized what's called perforation. The colon perforates a slight bit and you get an abscess and you have to stay in the hospital. So those patients we know have very aggressive disease and they may need surgery sooner rather than later, whereas the former patient may not need it at all. So I think to answer your question, we don't know, but we just need to kind of pay attention and treat the patient as opposed to the disease.
When you do surgery, is it done as an open procedure or minimally invasive?
Generally minimally invasive. Most diverticulitis cases that we see are elective. Of course, we do see emergencies where people have the free perforation in the hospital and require an emergency procedure. And those patients are more likely to get open surgery, especially if they have this has been going on for some time and the abdomen is very complicated when you go in. Elective procedures mostly are done in a minimally invasive fashion.
Thank you. Brad, let's go on to discuss another important topic that you all care for, hemorrhoids.
Every day.
Many of our patients suffer from that. Tell our viewers what are the different sort of hemorrhoids.
Well, we usually split them into 2 varieties, although patients can have both at the same time. There are internal hemorrhoids that cause painless bleeding and protrusion. Without a lot of external component to that process, they're the patients who are very commonly treated with office procedures. External hemorrhoids are different. They cause pain and they can get blood clots in them, and they're the ones that come into the office as a semi-emergency with a painful new lump, very commonly related to travel or change in diet or change in bowel habits. And they are sometimes have minor surgical procedures done in the office. The combination of the 2 problems that have been going on for many years occasionally leads to old-fashioned hemorrhoid operations, the kind of procedure we try to avoid. Patients would like to avoid it, and we like to avoid it also because of the amount of discomfort. So they've invented a few newer procedures for very large internal hemorrhoids have also helped out.
So give our viewers some examples of some of these office-based procedures you can offer patients.
The most common one still is the oldest of the procedures we do, which is rubber band ligation. That's been done since the 1960s. There have been new procedures come and go, but still probably the best of the procedures we do. We've actually been going back to an older procedure, injection therapy, because of the number of patients who come in on anticoagulants. That procedure dates back 100 years. It was abandoned in the 60s, and we're actually relearning it now because there's so many people on anticoagulants for heart problems and vascular problems that come in the office. So those are the 2 more common procedures we do.
And let's shift gears then to discuss another significant condition, rectal prolapse.
Mm-hmm.
What exactly is that?
Rectal prolapse is when not just the hemorrhoids are protruding, but a portion of the rectum, and that may be simply the lining of the rectum, which is called a mucosal prolapse, or the entire rectum sort of falls out to a certain extent, and I don't mean the full extent of the rectum, but a portion of it, which is called full thickness prolapse. And you may think about it as almost the rectum turning itself inside out. And the reason that happens is sort of multifactorial usually. The most common person who to develop this would be an older woman who has had multiple children, because there is during childbirth there is a weakness that occurs in the pelvic floor, which when you're younger you can compensate for, and as you age you may no longer be able to compensate for that, and the rectum may sort of sag out a little bit in addition to some of the other structures in the pelvis, most of the time, we can treat these with an improvement in fiber, bowel habits, but there are times when it leads to surgery.
And what do you do surgically?
There's two approaches to surgery, depending on the patient, their physical status, their age, the extent of the prolapse. So you can either remove it through what's called perineum, or just sort of excise through the rectum the part that's prolapsed out. Or sometimes if it's an extensive prolapse and it's a younger patient, you may have to go through the abdomen and sort of fixate the rectum to the bones of the pelvis to prevent it from sliding out.
So it's not so much that you remove a segment of rectum, but rather you fixate it.
Generally, we don't. There are times when you may have to remove a segment of intestine, but most of the time we try to simply fixate it if we can.
And I would imagine that is a lesser risk, therefore, of incontinence if you don't remove any part of the rectum.
Theoretically, what it definitely is a lesser risk of is recurrence. Removing it through the rectum, you're not actually fixing the mechanism of prolapse. You're simply removing the symptom. Whereas if you go through the abdomen, you're theoretically, removing or fixing the mechanism, which is the sliding of the actual structure.
Sure. Brad, what exactly is anal fissures?
Oh, they're the most common thing that brings people in the office with pain. I think an awful lot of patients who refer to us are from primary care doctors who think the patients have hemorrhoids and their primary complaint is pain. As soon as we hear about pain in the office, pain and bleeding together, we all very commonly start to look for a fissure. Mm-hmm. Fissure is a small tear. They most commonly occur in the back of the anal canal, most commonly also related to hard stools. Some violent, difficult bowel movement causes a tear, and that tear becomes a positive feedback loop. It keeps itself going. Because the tears in the anal canal usually tear down onto the local muscle in that area, and when they do that, they cause the muscles to go into spasm. And so even though you make the stool softer, the fissures can persist, and they occasionally need surgical correction.
What else can you do short of surgery to treat it?
Well, almost all of them are initially treated with a program that softens the stools. And a lot of the time we'll also treat the spasm. The spasm part of it's treated with very specialized muscle relaxing creams that are put in the anus, and they help a lot with getting these to heal without having to need any type of surgical procedure.
Now, I, of course, as a gastroenterologist, when I hear fissures in a younger person, I think it's a presentation of potentially Crohn's disease. Mm-hmm. Do you see that in your practices as well?
I would say the vast majority of fissures I see are sporadic without any link to Crohn's disease, but certainly people with Crohn's disease are at much higher risk.
So what do you think is the next big thing for colorectal surgery? What are they discussing at your meetings?
Well, it's been an evolving specialty. I think, I guess I've been at this a little bit longer than Vivek, and very few things we're doing now are the same things that we were doing when I trained. I think surgical procedures are evolving very quickly. We don't treat fissures the same way that we used to. We use Botox a lot now to relax the sphincter muscles instead of cutting it. There are all kinds of procedures that were the laparoscopic and robotic procedures, but what's coming along the line is integration. I think the bigger operations we're going to do are going to be very much like an airline pilot, where they integrate pop-up displays of landing strips and takeoff and airports. That kind of display, particularly with the robotic platform, is coming, where there'll be pop-up displays telling us where things are, blood vessels are hidden behind structures, and nerves are hidden behind structures. There's going to be a lot of integration of data into the surgical environments, and it's not very far off. And that's where the big changes, I think, are coming.
Artificial intelligence.
Artificial intelligence. And no one knows whether that's a step to the robot doing the procedure, we're watching it, or whether it's going to be an interesting time coming up, yeah.
Do you have anything to add to that?
I mean, I would agree with that. I think that is going to be a major leap forward in surgery. It's as simple as a leap. I mean, it's a complex technology, of course, but it's as simple as a leap as the reverse camera that you have in your cars. It doesn't make you reverse the car, but it helps you quite a bit, and to the point where most people are probably uncomfortable without one of those in their car now. I think some of the other advances are going to be more in the epigenetic realm, understanding the biology of tumors, how we can grade them, stage them, define them before surgery, potentially treat them without surgery. I think that's going to be a giant leap forward as well.
Terrific. So, Dr. Bennett, if our viewers have any questions, how can they reach you?
Well, the easiest way is we're still call our office and start from there. We do have, that will direct you to websites which have information. We have procedures online so the patients can review them and get more information about what's going in the office. But the best way is probably to start by contacting our office.
Okay, and that number is?
It's 301-681-6437.
Great. And Vivek, how about you?
I would say the same. Contacting my office, we have a great staff, and they'll helpfully get you in and answer any questions that you may have. Our phone number is 240-487-7522.
My thanks to Dr. Patil and Dr. Bennett for a terrific interview. My thanks to my team here at the studio, but most important, my thanks to you, the viewer, for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, it's clearly going to be a very important one. I'll be interviewing a member of the health department about the coronavirus, COVID-19. It will provide important information for you and your family. You will get more information about the broadcast dates in the near future. We therefore welcome you to another edition of Housecall. Thank you and good evening.